The learning objectives for this talk include learning the performance of brain ultrasound in infants, to learn the normal ultrasonographic brain anatomy, and to learn the ultrasound appearance of brain hemorrhage and ischemia and their sequelae in premature and full-term infants. We use a variety of transducer frequencies in the infants, in those babies who are quite large, those who are more than approximately 5 to 6 months of age and who are full term. We will generally use a 3 megahertz probe. We will at times have to use a curvilinear broad bandwidth so that we can penetrate to the depths of the brain. Normally the fontanelle, the anterior fontanelle, is opened until about 9 to 18 months of age. This could be open longer in babies who are premature or babies who have increased intracranial pressure. In babies who are somewhat smaller, we may use a 5 megahertz, and then in the babies who are premature or full term, we will, in the neonatal period, use an 8.5 megahertz. For scalp lesions, we will generally use a linear array probe that is at least 10 megahertz, often going as high as 17.5. The posterior fontanelle is generally opened until 0 to 4 months of age and may be open longer in premature infants and infants who have increased intracranial pressure. Now, we generally obtain our images using coronal and sagittal planes. In the coronal plane, we're going to sweep the brain from anterior to posterior, and we will be looking for certain landmarks. This is a drawing showing a coronal section of the brain in an infant. We can see the interhemispheric fissure, we see the cingulate gyrus, this hammock-shaped area below the interhemispheric fissure represents the corpus callosum, and then below the corpus callosum we have the right and left lateral ventricles, which connect via the foramina of Monroe bilaterally to the third ventricle. We also notice the Sylvian fissure. In the region of the Sylvian fissure, we will visualize the pulsations of the middle cerebral artery. Just above the corpus callosum, we will see the pericallosal artery, and within the cingulate gyrus, we'll see the pulsations of the callosomarginal artery. The goal of the sonogram is to image as much of the brain as we need to have a complete evaluation, which implies that we will at times be obliquing the transducer to the right and to the left to see over the convexities of the brain. The object of the sagittal plane is to examine the midline structures for anomalies and to evaluate in a parasagittal plane the ventricular system as well as the parenchyma of the brain. As we scan in a straight anterior-posterior or AP plane in the midline, we will see the corpus callosum, the genu, the body, the splenium, and just below the corpus callosum we'll have the cavum septum pellucidum. Below that area we have the third ventricle. We will see the massa intermedia when that ventricle is enlarged, and then this continues through the aqueduct of Sylvius to the fourth ventricle. We'll visualize the cerebellum and the cisterna magna as well as the brainstem. And depending upon the gestational age of the infant, we may or may not see the convolutional markings of the brain. As we look at the parasagittal views, we'll image the ventricular system, and as we extend our view more peripherally, we'll see the substance of the brain parenchyma. Bear in mind that when you're trying to visualize the ventricles, that the frontal horn is more medially positioned than the occipital horns, and so the anterior portion of the transducer needs to be more medially positioned than the posterior portion of the transducer. Let's look at some of the ultrasound anatomy. This is a very far anterior view. You know that this view is very far anterior because you can see the left and the right orbits. The interhemispheric fissure is seen here. And note that there are little areas of brighter echogenicity in the frontal lobes. This is what is referred to as the periventricular blush. It represents vascular markings as well as neurons as they extend from the deep white matter to the cortex of the brain. As we extend our view a little bit more posteriorly, but still in the anterior plane, we see that there is interhemispheric fissure. Here's the Cingulate Gyrus. We can see the Corpus Callosum here as a hammock-shaped structure that is very poorly echoic, that is just below the brain parenchyma here in the frontal lobes. We have a portion of the right lateral ventricle, a portion of the left lateral ventricle, and we're beginning to get into the areas of the caudate nuclei bilaterally, represented by these slightly brighter areas of increased echogenicity. We're also beginning to see these Y-shaped structures that represent the Sylvian fissures. As we come back just a little bit more posteriorly to an anterior mid-coronal view, we again see the interhemispheric fissure with the Cingulate gyri. We can see the corpus callosum and image the lateral ventricles. Note that the inferior lateral aspect of the frontal horns are concave, and that we can see the choroid plexus as it goes through the foramina of Monroe as brighter areas of echogenicity, and choroid plexus in the region of the roof of the third ventricle. The third ventricle may or may not be seen on the anterior mid-coronal views. Note the Sylvian fissures bilaterally, and also the bright echogenicity that is in the region of the hippocampal gyrus bilaterally as we look at the region of the temporal lobes. The little dots that we see centrally in the temporal lobe represent the temporal horns. A little bit more posteriorly, we get to the mid-posterior coronal view. Note in this view that we see this pie-shaped area of bright echogenicity that represents the cerebellum. A little bit farther back, we've reached the posterior coronal view, and we see these bright areas of increased echogenicity that are the glomi of the choroid plexus, which we'll look at in more detail when we look at the parasagittal views. These are generally quite symmetric. As we look a little bit more posteriorly, we see the periventricular blush around the posterior portions of the brain. And we're looking here at the occipital lobes. The periventricular blush represents vascular markings as well as neurons that are coursing from the deep white matter to the cortex of the brain. One may encounter a variant where there is asymmetry in the size of the choroid plexus that is basically physiologic and not indicative of an abnormality. Note that the right side of the baby's head is up on this particular view. Remember that the choroid plexus is buoyed up by only one part of the roof plate, so that if there is a change in the position of the baby's head, the side that's up tends to appear larger than the side that is down. Notice when we turn the baby's head the other way, with the left side up, we now see that this glomus of the choroid plexus looks as though it is larger. It really isn't. This is an artifact of positioning. If there's ever a question, you can always turn the baby's head, of course, with the support of the nurses, because most of these babies are attached to life support systems, and it is extremely important not to dislodge an endotracheal tube or other intravascular catheters or enteric tubes. Also consider the extra-axial fluid spaces. We measure routinely the sinocortical width by identifying the superior sagittal sinus, measuring from the sinus to the outer margin of the cortex of the brain. In a normal baby, we'll see that the sinocortical width measures 0.4 to 3.3 millimeters. We also routinely measure the craniocortical width. This is the depth from the cranium to the cortex, and this should not measure more than 0.3 to 6.3 millimeters. We measure the interhemispheric fissure, and this should not measure more than 8.2 millimeters. Here's the ultrasound rendition. We're measuring from the superior sagittal sinus to the cortex of the brain bilaterally, and we're measuring from the cranium to the cortex of the brain, as well as the interhemispheric fissure, and all of these numbers fit into a normal range. Also consider the presence, the number, and the configuration of the gyri, which are proportional to the gestational age of the infant. Notice that it is not until 26 weeks gestation that we begin to see the development of the cingulate sulcus and gyrus. As the babies mature from 26 weeks gestation up to full term, there is an increase in the number of convolutional markings until at term there are multiples. This is an important detail to be aware of, as there are certain congenital anomalies of the brain that are associated with lack of formation of the convolutions. The corpus callosum should be looked for on every brain ultrasound study. This is the largest medial interhemispheric commissure that contains fibers that interconnect the cerebral hemispheres, thus allowing for sharing of memory and learning between the two sides of the brain. The corpus callosum forms during the 3rd to 4th fetal month. It grows as a bud from the lamina terminalis, grows upward and backward, while the brain grows laterally and posteriorly. Notice, too, that there is a fluid space below the corpus callosum. This is the cavum septum pellucidum, and the more immature the baby is, the younger the gestational age, there will be a posterior extension to this fluid-filled space called the cavum vergae. This should not be mistaken for a cyst within the brain. So here we have the genu, the body, the splenium of the corpus callosum. And here we see the ultrasound image of this anatomy. This is the genu of the corpus callosum, the body, the splenium, with the baby's head facing to our left and the posterior aspect of the baby's head to our right. This is the cingulate gyrus, and here we can see that there is bright echogenicity right below the cavum septum pellucidum and the posterior extension, the cavum vergae. This represents the choroid plexus in the roof of the 3rd ventricle. This is 3rd ventricle, and you might question, why does this 3rd ventricle not look quite as anechoic as the fluid that's in the cavum septum pellucidum and the cavum vergae? The 3rd and 4th ventricles are extremely slender. They measure no more than approximately 1 to 2 millimeters in width. And therefore, it is somewhat difficult to get an image that does not pick up specular reflectors from the brain tissue on both sides of these midline ventricles. So here we have the 3rd ventricle with the region of the aqueduct of Sylvius going down into the area of the 4th ventricle. We have the cerebellum, this very brightly echoic structure due to the fact that it's quite vascular and there are multiple convolutional markings. Below the cerebellum is the cisterna magna, and this should be looked for on every midline ultrasound view. And here we have some increased echogenicity in the region of the brainstem. Notice that the brain itself in terms of the parenchyma is a relatively hypoechoic structure. So here's the genu, the body, and the splenium of the corpus callosum, third and fourth ventricles. This is a baby who's somewhat more mature. You can see that there are more convolutional markings. They're a little bit serpiginous, which happens as they develop. And here we have the genu, the body, and the splenium of the corpus callosum, with a remnant of the cavum septum pellucidum. This line that you see centrally represents a septal vein. Again, choroid plexus in the roof of the third ventricle, the aqueduct, the fourth ventricle, the brainstem, cerebellum, and cisterna magna. Notice that once the babies become full term, there is less visualization of the cavum septum pellucidum. Sometimes it is totally obliterated by that age. And here we see the genu, the body, the splenium of the corpus callosum, the choroid plexus in the roof of the third ventricle. Here's the fourth, the brainstem, the cerebellum, and the cisterna magna. Parasagittal views allow us to visualize the lateral ventricles, and we see here the bony structures of the cranial vault. This is the anterior, the middle, and the posterior cranial fossae. We have more convolutional markings seen on this particular image, and we can see the various parts of the lateral ventricle. This is the frontal horn, the body, the atrium of the lateral ventricle, where the body, the occipital horn, and the temporal horns meet. Housed within the atrium of the lateral ventricle is the glomus of the choroid plexus. This should be very smooth, and it should taper toward the caudothalamic groove as well as toward the temporal horn. We should not see choroid extending into the occipital horn of the lateral ventricle. Note that there is an area anterior to the caudothalamic groove that is called the germinal matrix, and we'll talk about this in more detail in a minute. We also have the region of the caudate nucleus and the area of the thalamus. You'll notice there are little fine lines that radiate back from the posterior aspect of the body of the lateral ventricle as well as the occipital horn. This is the periventricular blush that I alluded to when we talked about the coronal plane imaging, and these represent the vascular markings as well as the nerve fibers that extend from the deep white matter to the periphery of the brain. The initial description was that these lines were reminiscent of the strokes of an artist's brush. Extremely important to see this detail and to be sure that it is less echoic than the glomus of the choroid plexus. If this area becomes brighter than the choroid plexus, we need to be concerned about hemorrhagic and necrotic changes, and we'll talk about that when we discuss ischemic disease of the premature brain. Going back a little bit more towards the lateral aspect, we can see the Sylvian Fissure, and if we would turn on Doppler, we would see the pulsations of the middle cerebral artery. And coming out a little bit farther laterally, we see the area of the insula. We also get another view that's known as the occipitomastoid view, where we use the probe right behind the ear along the region of a little opening in the skull known as the mastoid fontanelle. It's really only possible to see through this area in very young babies. And this allows us to see the lobes of the cerebellum. Notice here the right lobe, the left lobe, and we can see the area of the cisterna magna. A little bit easier to see when we put it into a view which is in a more vertical presentation. Now, when routine coronal and sagittal images do not completely image abnormalities, we use whatever approach works. For instance, we may use oblique views via the anterior fontanelle to demonstrate a ventricular shunt tube. When there are posterior fossa lesions that we can't image using an anterior fontanelle approach, we'll use the posterior fontanelle. We'll also use axial views if we have difficulty following the course of a shunt tube, or if we want to demonstrate an extra-axial fluid collection in its entirety. It's helpful at times to see the brainstem with an axial view, the cerebral peduncles, the middle cerebral artery, the posterior cerebral arteries, and the anterior communicating artery of the circle of Willis. We can also use whatever other windows there are through the cranial vault